Coming out tonight.
Hey everybody, like Dr. Smith said, thank y'all so much for coming out tonight. Because this is the first time we've ever had Dr. Cherry here with us. He is an oral surgeon from Greenville. He works at Brushy Creek Oral Surgery. And he is going to come and tell us all about his undergrad, his dental school residency, and information about the MD and DDS programs to get licensed for both specialties. So if you could, please help me welcome Dr. Brian Cherry.
Thank you. I wish I had a program like y'all's at College of Charleston. Maybe I said no about it, things. But I'm from Greenville, all my grade school there. And please slow me down if I talk too fast. I'll try to do this in about an hour and 15. Okay. And then we'll get some questions and answers, or whatever y'all want to ask. It's very informal. I'm Brian, and so whatever y'all want to do. I went to high school and then went off to college, Charleston, played soccer down there, so I was in that whole mode, and then biochem major down there. I wasn't really pre-med. I just knew, hey, let's go biochem, and I can go a couple routes there. Kind of was my own advisor. I had one. She was chemistry, really, as my advisor. Did biochemistry, and then as I was wrapping up, I was on my 5-year plan, as Charleston usually is. And so kind of in my 4th year, I said, hey, I know I wanted to do something in medicine. And I started just asking around friends, anesthesiologists, primary cares, my dentist in Greenville. And I got the same thing. It's like, all right, if you want to treat sick people, be a doctor. If you want to deal with insurance, okay, be a doctor. If you want to be a dentist and don't want to treat the sick and just have them come in, then be a dentist. You can work 4 days a week, and most of the time you have good hours. And insurance hadn't hit yet, but it was starting in California and in Massachusetts and moving its way over. So I said, all right, I want to be a dentist. But I kind of still did the MCAT at the same time. Studied for the MCAT, didn't do so hot. I was about a year or 2 out of school. So suggestions with that, if you're doing MCAT, is take it while you're in school. Take it while you've had organic and physics, or recently had those, because it's pretty darn hard to study those things afterwards. What else is on? I know MCAT has added a couple of other subjects in there. And of course there's reading, which I'm not very good at. I'm more of visualization. I'm that side of the brain that's just visualize and kind of repeat it out. That's just, I took a year or 2 off. I played soccer for a year after that professionally, then coached it for 2 years, and went back to school, got my biology degree. So took the DAT, which is the dental aptitude test. Did better on the second time, and then got in on my 2nd try. First question is medicine. Who is like general medicine, whether it's the DO program or the physical therapy or health administration? How many are that? We're going that route. You want to go that route? Okay. All right, cool. So at least half. How about dentistry? Anything? Okay. About 5, 6. Okay, cool. We have at our office there in Greer, South Carolina, we've had students shadow us. Prospective students that are just out of college, and you're more than welcome. We are an open door policy. We don't beat our chest down and say, we're oral surgeons. We just like to teach, both of us, Dr. Bryant and myself. So I got into dental school, and again, break up with a girlfriend, so I said, you know what, I'm going to show her I'm going to be an oral surgeon. She didn't want to stay in Charleston. Okay, great. So I just studied my life away that first year, or that first summer, gross anatomy, and neuro anatomy, that's what it was. Got a 4.0 on that, and a couple other small things. So that's the summer, and it's just pretty much gross anatomy. But going into dental school, going back to my 1 or 2 years off, I had taken histology, I had taken embryology, again, I had taken one other course. So when I got into dental school, when I found out in the first 2 years of the academic, like the medicine route, is I had taken every course that dental school that you would take in dental school the first 2 years. So it was like I was taking biochem the second time, histology the second time, and all this. So that really helped. And as you know, going through college, whatever happens in your first year, you make good grades in your first year, it really sets the tone. It helps out that first year. So if you go into dental school or medical school, go hard at it the first year especially. I'm not saying you slack off on the fourth year. I did it, but I went now from 3.93 to a 3.6. I'm just here to tell you my real story, my life, and that's just who I am. And then I applied, and then I said, all right, I'm going to oral surgery. I went on a couple mission trips to learn to take out teeth. Probably wasn't the right way to take them out, but I did it. We got it done, with headlights and darkness. And actually, you can probably, attest to that. In the darkness and still working. And so it's just a great joy to do mission trips and anything that I can do to help my profession and my love for dentistry. Hi, how are you? Brian. Can you see?
Sorry for being late.
No, you're fine. I've been plenty late all the time. So that's oral surgery is what's called a match program. Very the same thing as the medicine program. It's the only specialty of dentistry that goes through the match program. My wife's a pediatric dentist, and that's more just an application process. She went to Marquette Dental School, did about 3 or 4 years of health, community health, which is your lower income and rural in Champaign, Illinois, and then she did 1 year residency, minor residency in St. Louis, and then decided to, and I'm glad she did, move to Boston, okay, and pursue a pediatric dental residency, where I met her in her second year and my third year. So her second year was the last of pediatric, my third year was the second to last. But going back to dental school, we just hung out around the surgeons, got what, wanted to do, know what I wanted to do, and applied to 10 schools. At that time, I was dealing with, it was like monopoly money. Okay, thank you, federal government. I'll take more money. Apply for it. Here comes more money in. So okay, I was buying PlayStations and a couple things. And right now, dental school is a lot more expensive. A lot more expensive, and so is, I presume, medical school. And it's getting tougher too. But anyways, where was I going with that quick story? Oh, I applied to, my first choice was Medical College of Virginia, Richmond, great program, good history. They did a lot of things. Second choice, Ohio State. They had just won the national championship in 2002. And then Boston was my third choice. Fourth one, Charleston. Fifth one, Atlanta. I think maybe Emory. Iowa was like number 7. I was like, okay, but can I last there 4 years? Okay, and so Boston, because I went to a best friend up there for I interviewed at Tufts too, which is up there. Football game, a basketball game, a couple bars. Had some fun. So I said, hey, this is a good place for me. So wherever you're going, just make sure that hey, you're there to study, but I have to have a life. I have to lift weights or play soccer too, but I can can regiment things, and that's the most important thing.
This is for dental school, right?
This is the dental school was right out of college, so I went to dental school and then I applied for oral surgery. So let me go back a little bit. In college, I applied for dental school and medical school. I took the MCAT, that is, in my as I was done. Meaning, I had a biochem major. I didn't know what to do with it. No idea. Well, you can go to West Vaco, if you know Charleston, which is in North Charleston or somewhere closer to, a little bit north on Highway 17. I said, oh, I can go and be in the lab and titrate things. Awesome. And said, nope, not for me. So I said, okay, I'm definitely going for it. I'm going to take the Kaplan. I took the MCAT Kaplan. Still did my other side things, such as some coaching of soccer, and just found things that were good for me, in that year off that you might spend, or, I think of wedding you might spend a year, type of thing, but those are just things I did well, and, really made me feel good, and still don't get bummed out. And that's the biggest thing is when you go and apply these schools, you know, and they say, well, try again, let's go here, I'll let you do this, or go assist somebody, or go shadow somebody. Also find a life where you don't get bummed out. Because I know it's hard, but you got to stay focused. And you can only stay focused, in my belief, if you're healthy. I'm not a shrink, but it's just something. So that's what I did. That got me into dental school. Dental school was pretty much ho-hum. You know, I just studied. Charleston, I'd already been there for a while, already known it. Kind of did just the same old routine as if I was back in college almost, but a little bit older. So I got, and then through then at dental school, the very end of that, I, in my 4th year, said, okay, I'm going for it, oral surgery. I don't care if I gotta wait a year or 2 again. I can go and practice dentistry somewhere and then apply. But thankfully, I did match that year. Hey.
Dr. Cherry, did you go to dental school at MUSC?
I did.
Okay.
I did. I interviewed at Baltimore, MUSC. I can't think of any others. You know, the odds weren't very good, but I was just hoping. But I definitely stayed, when we were talking at dinner earlier, is I stayed in their ears at MUSC, in that dental school, Dr. Javed down there. So I said, hey, I'm coming to College of Charleston, got a good reputation. The good reputations here are this. I do know this in dental school here at MUSC. College of Charleston got a good science program. Wofford had some from Clemson. More or less, actually, Clemson here is engineering and the non-pre-docs. I don't know why that is. But there was a lot of engineers that came out of that. I love talking to an engineer when I'm talking about implants because they get it. You know, when I put an implant, they just get it. The torque, the forces, the vectors. It's like, hey, this is too easy. You know, so, but that was kind of where the feeders were coming from. The Woffords, College of Charleston, Citadel, Clemson, not so much South Carolina, a couple in South Carolina, and then minimal out of state. The ratios, female to male, was at mine 16 ladies to 30, about 30 guys. I'm hearing it's becoming a little more 50-50. Yeah, so I'm hearing we're pretty much in touch down there with people that come out of there. So residency in Boston, I was very lucky that I didn't have to wait a year, and I said, okay, I'm going. Found a house, a condo right across the street from Boston Medical Center because I only want to live close. I don't like driving in. When I'm on call, I like staying in my own bed and not in the call room. I did that a couple times though, but and my password at that time was, my vision was in 2003. My password was South Carolina 07, 2007, because I'm out of there. I'm out of there. So 4 straight years of doing what I needed to do, giving my best effort to learn my trade. And I'll go through a lot of what my experiences were in this lecture, specifically to oral surgery. Any questions about leading up to where I got from 2003? 2003 is when I went into oral surgery, to 2007.
Tell me a little bit about the match program.
Okay. What I remember, again, is in that match program, you go and interview in about September, October, November. A lot of them do it kind of in the same time, maybe a couple days apart, so you can be flying from one to another. And your odds, you go, and obviously your odds are better the more you visit, or the more they accept you to visit. So I think they send you a letter back first, and then you agree to go to the interview. So I did about 8 or 10. I think I only went to 8. And so I confirmed I was going, and I would be there, because you don't want to never confirm and not be there. I just want to see that as ethical, as an ethical thing. So interviewed. One interview at Ohio State was about half of you guys on this side, and me in the middle. The Buckeye rolling. I don't know why, for good luck. But the rest of them were 3 or 4 attendings just sitting there, you know, just kind of, or you go from one room to the next room to the next room, and they're just shooting the shit with it. So, they're really not asking you anything really pertaining to oral surgery. They're like, why do you want to do it? What are your interests? They just want to see that you're a good guy or a good gal. That's all they want to see. Can you get along with your co-residents? And more importantly, can they trust you to see their patients? That's the bottom line. They don't care how much you know. They're going to break you down. Okay? It's like plebe year or intern year. They're going to break you down, and they're going to tell you you don't know anything. And that's pretty much that's true. I didn't know anything anyways, but you know, so there's a method to it. And when you go into interviews, go and evaluate what their academic routine is. I'll tell you right now, MUSC oral surgery program is in some trouble right now because their chairman passed away. So you got some people out of, and MCG was that way 10 years ago, I think, when people were saying don't go there. Look at their academic program. If you're academic, look at their academic program. Do they have weekly rounds? Grand rounds? How often do they have that? What do they cover? What are their rotations like? Some are just not fly by the seat of your pants because they got to meet some criteria, but some are not as regimented, I guess, is the right word, or structured as others. It's resident driven. Of course, what that means is the residents learn themselves rather than attending driven. So I had about 6 or 7 instructors that we have an anesthesia rotation here, or an anesthesia lecture and journal review once a month. We could have outside speakers once a month, talk about different cleft palate, obstructive sleep apnea, bone grafting, jaw surgery, X, Y, and Z. We would have pathology review every month, sit down with pathologists, go through cases, that type of thing. And not every program out there, whether it's medicine or dental, is like that. Okay. So that's just my suggestions. Y'all can email me too. If y'all, there's my email right there. If y'all have any questions about how to attack an interview process. I don't have all the answers. I have some, but they're a conglomeration of what I've heard as well. Match program now. So you put down a name, you put down who's number 1, number 2, number 3, number 4, number 5, as many as you want to put down. I think they cost money to do that. I don't know. I forgot. And then they being the schools, put down who they want, 1, 2, 3, 4, and 5. It all goes into a computer software system, and then it links up somehow, some way. Well, mine was number 3, and I saw the statistics on this is that I don't want to throw that. 80%, and I'm just kind of throwing that out there, got their number 1 choice. 10% got their number 2, and then, well, probably less got their number 3. Okay, so I was just very lucky. Maybe I caught a break or won the lottery. I don't know. Anything else? Any other questions about lead up to professional school? It's high school and college. Just have fun. Find out who you are. Because I tell my parents, my sister will find herself at the age of 24. She will find herself at the age of 24. I don't mean that derogatory. I'm just saying, when you go through college, we're all just, finding what we can really do, what our potential is. Of course, we don't know our potential until we get out there, in these schools, and then even out of school, per se, by the age of 30. And then we say, you know what, this is what all I've trained to do my whole life. I've been under this umbrella, whether it's parents and insurance or a school, and now the school has malpractice over you, so you can do, you can mess up, but there's somebody to fix it for you. Just like as a kid, you can mess up, and there's parents to fix it for you. But the hardest thing that I've had to do for the last 6 years is my wife and I get married, have 2 children, pass my boards, oral boards, and once I got done with that, I didn't know what the heck to do. I'm surprised I'm sitting still right now. I'm just I move all the time. My patients say, "You got ADHD?" I said, "Yeah." I do. I do. I talk fast. You know, try to slow it down when I'm presenting a treatment plan. And say to the patient, "You understand? Are we clear?" "Yeah." "No, we're going to go through this again." So that's what I've learned through my training and what I'm going through now, 6 years out into private practice. Is, accepting my decisions and how they affect others, including my family. And it's a tough thing. It doesn't get any easier. Anything else leading up to that? I'm going to try to run through here what I do. A lot of this has medicine implications because we spend in our residency all our time in the hospital, very little in the dental school, which is more like a private practice. I think if I just click, I go to the next one. Yes. All right, the history of an oral surgeon. Basically, you had your barber surgeons. Okay, those are in Europe, and barber surgeons were the surgeons, the barbers, and the tooth pullers. And the bloodletters. So bacteremia, and you let out blood. If you gave blood back then, that's what they did too. And so London College of Surgeons, they separated in 1745. The London College of Surgeons, which then became the American College of Surgeons on this side of the pond, was established. And the barbers continued on with the hair cutting and the tooth pulling and the bloodletting. So this thing going around, supposedly, I don't know if I picked this off of Wikipedia or not, which I don't trust, but is, you know, the rags they used to use, you know, and napkins when they cleaned it up, white and red, the blood, from the bloodletting. Who are oral surgeons? When we fill out a hospital form or a hospital application to a center, we are, our organization has kind of fought for us, and hospital administration, given us the ability in a hospital to treat the hard and soft tissues of the neck over. And that includes everything. You know, jaw up. Sometimes you can come down here, just depends on your level of training. But that's tooth pulling, that's soft tissue trauma, soft tissue pathology, hard tissue pathology, trauma. Infections, most infections, swellings of the face, they're tooth-borne. Okay? Very rarely, if you get a swelling of the neck or the other face, are they not tooth-borne. If they aren't, you need to make sure A, rule out cancer, B, you know, then you can go to your other little small diagnoses of like a fat tumor, a lipoma. All right, reconstruction of trauma pathology, we'll go over that. Cosmetic surgery, a lot of them do cosmetic surgery. We all know what's popular now. Botox, Juvederm, facial cleansers. Anybody else? Heard of anything? Seen anything? Yeah. Lip implants, that's Juvederm. Chin implants we do. Lefts, facelifts. Dr. Bryant does those in his office, called the modified, the lower. And you can do, instead of doing a hospital, he does modified under sedation, about an hour and a half long. I don't do it. I don't have the knack for that, the patience for that, and the little here problem. Okay, I just like to keep going. Orthodontic surgery is breaking the jaw purposefully, the maxilla or the mandible, or to correct facial deformities, sleep apnea, amongst other things, TMJ surgery. But it's all up here is where the bread and butter is. Here, here, not so much here, rarely here, that's the bad one I'm talking about. But this is all the bread and butter. And these are all under sedations or just lidocaine, which is a local anesthetic. Okay. This is sort of what I was trying to explain earlier, is about 50% of the programs out there in oral surgery are a 4-year program, the other ones are a 6-year program. So if you decide to go into oral surgery, you can choose the 4-year route or the 6-year route. The difference of the 4-year route is you get a certificate of advanced graduate studies in the 4-year route, meaning first year is oral surgery, second year is a general surgery internship, and you get a certificate for that. Third year is a kind of, you're the low-level senior or the junior resident, and then the fourth year is what's called the chief resident. You run the ship there, and you work very closely with the chairman. All right, the 6th year, the medical degree. So if you see an oral surgeon out there or a plastic surgeon, then they may be oral surgeons starting out and going to plastic surgeons. There's one in Charleston. You get a DMD, usually first, because that's your first dental school. And then they go to oral surgery residency. And then they do, the first year is oral surgery. The 2nd year is internship general surgery. The 3rd year is general surgery year 2, just like in any oral surgery medical program, surgeon programs. I know there's a 1 and a 2. And then the 3rd year, something else. And then the 5th year is a senior resident, and back to oral surgery. And then the 6th year is a chief resident. All in all, you're away from oral surgery, in my opinion, for 3 years. And you're doing medicine, urology, GU urology, ENT, belly surgery, you name it. Okay, great. I mean, it doesn't give me or them any other privileges or any significance besides in an academic center that might be looking for this exact criteria. These are just the national memberships that I'm part of. Everybody here, go into the medical type field, or any type of line of work, you're going to be part of some memberships that you're almost required to be part of. Back in Columbia, I was part of what's called a Level 1 Trauma Center, Richland Memorial. It's the same thing as Greenville Memorial or Augusta or Emory, Grady or Cook County. You name it. But this is actually now, I moved to Greenville. I want to, because I'm from Greenville, and I want to get away from those night calls, those 2 a.m. calls, where the residents are calling you, and they got to go to another trauma, and so I'm stuck with something. Now I got to go be a resident again, basically. I got to go and get my own things. God forbid. But this is a level 2. I've gotten in the last year 1 mandible fracture, a couple nasal fractures, and life has been good. I get to have a family life, and that's what I want. Again, the reason for probably Boston is this. All right, and I lived right across the street from that. So back to it. That's my 1st year. It's just a surgery rotation. This is Boston Medical Center. This is Boston University School of Dental Medicine. And this is a VA rotation. You see with a lot of sick people at the VA, and that's a good. All medicine goes to VA. Almost all medicine goes to VA. And then I did a medicine, cardiology, infectious disease, and those are 1 month each. So we learned the basics. So going into the next year, which is the general surgery year, this is where the general surgeons, the chief residents of general surgery, like the oral surgeons, because we already know what's going on in the hospital. And we've kind of already been through this, and we know the program that they use, and we know how to get around and round on patients. Whereas as interns and 1st years that are coming fresh out of medical school, they're a little bit more shell-shocked. Because now, hey, I'm out of school. I'm now in the, hey. Okay, yeah, you raise your hand. Yes, you're exactly right. Remember those years? Adam Vinatieri, Richard Seymour from Lower Richland High School. I actually went to his house. His mom is a clerk court down in Columbia. And it was the day before game time. I was eating a bunch of chicken wings. He sees these 4 guys come in and a fist bump. Hey, I'm eating my chicken. This was on Saturday down in Norfolk. Him and Willie McGinnis were right next door to each other. All right, so that's my rotations. Okay, anesthesia was my most important. ENT was as closest to me. ER, I didn't like 12-hour shifts. The ICU, sick patients, didn't know what to do sometimes, and that's just the breaks. Trauma surgery, general surgery, neurosurgery. I touched 1 brain. That's it. And I told my dad I'm a neurosurgeon for the day. Plastic surgery, we just rotated. We really didn't do a lot of that. CT surgery, again, I held a heart, I held a vein. I put a clamp on some Prolene suture, and I got my hand bit off because Prolene suture you're not supposed to touch. So I hope that guy's artery is still doing fine and intact because I weakened the suture. So these are all things that we all go through as residents. Oops. Prolene suture is a very thin blue suture, okay, used for the skin. The blue ones that you see. They also use the same thing to tie it to put the arteries together on bypasses. And the CT surgeon at the VA hospital, and I put my little just pickups, little forceps, right on the ribbon. And of course, that made a little deformed the ribbon a little bit, and hopefully it held the artery together after that. But he did 4 or 5 others too, so I don't feel too bad. This is not when my kids were born in 2005, but this is my princess who rules the house. Not, I don't think her mother rules it anymore, but and my 7-month boy, and all I need is a dog for 2.2. Back to 3rd year. Okay, back again on another anesthesia and a cleft lip and palate rotation. Okay, we're going from Boston. This is Columbia, and in preparation for private practice. Get a little warm in here. Excuse me. So my girls in Columbia said this would serve me well here in the upstate. Okay? So I go from Columbia, wearing Garnet, just because, you know, I've got to now this. So this is how I grew up a little bit. Okay, Clemson. I was black over here.
I see it.
Okay, cool. So right under here I can put Columbia 2007 to 2011, and then 2012, beginning of 2012 to now. Okay, the perception of an oral surgeon. This is the common perceptions of what we do, and if you don't have that perception, we're going to teach you. Take teeth out. This is just splitting some teeth. That's a 3rd molar socket. When you had your wisdom teeth out, that's the hole we made. Yes, the hole's as big as the tooth. It has to be. Okay? So, the holes are that big? Yes, they are. Pus. Alright, dental infection. I gotta let that go a little too long, don't you think? Yeah. I think I got him or one other guy. Usually they're diabetics that are when they're that bad. Alright, this is TMJ surgery, just like a knee scope. You're putting a scope into a TMJ. I actually did my 3rd year and published paper on arthroscopy of the TMJ joint. This is a new, just like a knee joint, this is a TMJ joint. I'm sure everybody's heard of TMJ. Every 50-year-old lady has heard of TMJ, with fibromyalgia too. I sent them down the street. Knowledge of the head and neck anatomy. You know, I feel we know it pretty good. IV sedation. Also, you guys put people to sleep. Yes, we do. And you only do this. And I said we go pretty darn sleep. You know, I don't want to pay my patient to sit. Like, I'll get my story straight. It's been a long day. Hear, see, or remember anything. There we go. Those are my my spiel. I don't deviate too much from it. I try to change it up every month, maybe, because they hear the same jokes. At least my girls do. But you're not going to see anything, hear anything, remember anything. You're going to wake up, you're going to be fine, you're going to be numb, you're going to walk out of here, you're going to be goofy. You might be on YouTube if you put yourself on there. And you're going to do great. Because we have no complications here. I don't you say that. Okay. Hey.
I was just going to ask, what are those?
Those are implants. Actually, these are that. Well, I'll tell you what that is. That is the implant. That's the screw. These are what's called paralleling pins. So we've already made drills. Just like you take a drill, you put it in a stud, you go drill, drill, and you want to make them parallel. So you drill, drill, go to the next side, drill, 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 drill. But you parallel. You put this pin each one you go.
Where did their teeth go?
Oh, this young lady was a 22-year-old, and I'll go over her. This was a 22-year-old lady that had 2 rounds of orthodontics and root resorption, and her 4 front teeth at 22 were loose.
Oh, no.
That's what happens when your orthodontist moves teeth too fast. When you say, I can do that, when the orthodontist says, I can correct your bite in the ear, just ask questions. Hi, I'm Brian, how are you?
Hi, I'm doing well.
Good, good,
Thank you
good.
for having me.
Oh, okay, thanks for joining us.
Do you put like fake teeth on top of the spikes? Or do you take the
We
spikes?
will eventually. Oh, we will take, no, that implant, so basically, here's the first implant going in that hole. That implant goes in, put a little cover screw on it, which is called like a manhole, over the top of a hole. I take that out, put my next implant in. Take that out, put my next implant in. These are just paralleling pins, so when we actually make our holes,
Okay.
you know.
So they don't walk around with like fangs like that.
No. Alright, so this is my stance here, you know, it's not, you know, I like to stay like that. If I'm not, I don't know what my girl's telling me, because I don't want a bad back or cervical spine or that. But, you know, this is a quick basic setup. EKG, monitor blood pressure, pulse ox. Okay, we're going to get a little more here. So this is another way of doing oral surgery prior to putting in implants. you take bone from the hip. Oh, you guys take bone from the hip? Absolutely. You feel this bone right here, how hard it is? It's a quick dissection right down there. Retract the tissue. Take a saw, cut it off, cut the blocks up into smaller pieces, screw them in place. This young lady got hit with a tire arm in Boston. It's all interpersonal violence in Boston, isn't it? There aren't any car wrecks because you can't go fast enough.
Nope.
It's all tire arms, baseball bats, and South End now. That's a different story. And Dorchester and Charlestown, the townies, you better just watch out. You just better run.
You don't go there.
Yeah, you don't go there. And if anything happens, you can see anything. Level one trauma service. Okay, this is a guy who got hit by a boat propeller. I'll talk about it in a minute. I thought it was an airplane propeller first when it came in. Has anybody heard of these bisphosphonates? Fosamax, Boniva, Actonil, reclassed. Anybody seen Sally Field on commercial?
Yeah.
You know, she's walking through a field and my bones are brittle and I'm going to take this drug and I'm going to be good, okay? Well, this is what this drug, this is actually an IV form. And this can be an oral form. If you take these long enough, this is what they're doing. What they're causing in the mouth. And I'll go over again why that is. Alright, well, I'll look at myself too long. Medications, so they're now safer than ever. They're less allergenic, okay? They're quicker acting. That fentanyl, that propofol, Michael Jackson drug. I don't have 2 girlfriends with 2 phones. I'm not answering the phones like that cardiologist did. So they said, oh, the Michael Jackson drug. I said, that's my spiel. I said, yeah, I don't have 2 cell phones that are going off, which is what he did, with 2 different girls, and not monitoring the patient, which is Michael. Hence why he died. And that was proven, because it was in his body. Outpatient surgery, surgical center, rarely. Office-based surgery is now becoming more proficient, faster. Money. Anesthesia, safer than ever. Remember when we were going around the room earlier, we were saying levels of sedation? There's different levels of sedation. There's the awake, and then there's a laughing gas. A lot of us know what that is. We're just, hey, everything's funny, I can tell a stupid joke and they'll laugh. Great. That's a good time. Then there's the IV route. We can put you in a la-la land, and you can still respond, but you don't care. Then we can put you in moderate sedation / general anesthesia, which is called deep sedation, where you lose your reflexes. Sometimes they don't breathe because, I'm not saying I'm unsafe, but we give you so much, but I know you have a good airway, I may have to bag them for just to give them some what's called rescue breaths. Okay, it happens. It happens. You know. So that is different techniques: light sedation, deep sedation, and it's surgeon dependent. So it just depends on your comfort level. And I learned this out of dental school, by the way. I learned this. Here's what you need to know. When you go to professional school and train, any of them, the way that you're trained is they give you a foundation. And correct me if I'm wrong. They give you a foundation to learn. When you leave that professional school, you are not I would be willing to bet that you're not going to practice the way that you were trained with that foundation. Am I incorrect saying that?
No, you're good. That's good.
You know? And
There's the art and there's the science. Is that sort of what you're getting at?
yes. There's the academic way, and there's the private practice way, or the putting it all together. Okay. So basically, you're regimented. You do this, and this, and this. In a private world, in the community, when you're trying to be real gentle, and I don't have the big hospital to help me out. You've got to sort of tailor it to each patient. Each patient is a different story. I mean, that's what I love about what I do. Every tooth is a different tooth. Every patient is a different person. So, all right. Oral surgeons, deep sedation, ACLS certified, IV versus inhalational. Inhalational is breathing it in. Basically, with this right here, I got to have American Dental Association guidelines. I got to have 3 people present to do that. 1, I'm the operator. 2, another assistant that's basic life support. And then 3, 1 reading the monitors. Because they say that I cannot be the procedure guy and I can't supposedly read the monitors. Okay. 2, equipment. You got to have certain equipment out there. Positive pressure. You got an EKG, pulse ox. blood pressure monitoring every 5 minutes. And now they're requiring us to have, anybody know what a capnograph is? It's a CO2 monitor, because we all blow off CO2, a certain percentage of it. Okay. 95% of my practice is in this deep sedation general anesthesia of those that are IV sedated. I don't want them to remember, hear, see, or remember anything. Okay? Moderate sedation, I'm going to do those for the cardiac patient, the angina patient, the sleep apnea patient, because that 250-pound guy that's got an 18-inch neck, no chin, he snores at night, okay, y'all get the picture? All right, I'm not going to put him asleep where he's not going to breathe on me. Okay, you're going to go la-la land, and you're trying to move this. It's called restrictive lung disease. COPD, obstructive lung disease is asthma, emphysema, and one other, bronchitis. Restrictive is big belly, moving a lot. That's restrictive. So if you can't move a lot of your belly and you're doing a lot of that, we ain't going to sleep. These are just grades of classification of how sick you are. That's a constant, that level is a constant threat to life. And we get them coming in the office every now and then. Okay, what this is saying that in oral surgery alone, IV sedations, this is a malpractice, people, that the rate of mortality is 1 in 800,000. Okay. Yes, we've had a couple of deaths in this state under IV sedation in the last 5 years that I know of. At least 2. 1 was a young girl. 2, I think, was post-operatively sent to a hospital that bled to death, bled out, obstructed the airway. Not all of them oral surgeons. One was a general dentist / periodontist, another was an oral surgeon, and one with Rockhill and one in somewhere else. The general anesthesia in hospitals, per the Massachusetts Anesthesia Association, this is with anybody undergoing an intubation, is 1 in 500,000. Okay? Of course, that doesn't, I don't know the specifics of that 1 in 500, how sick those patients were. All right. These are complications. Okay? Syncope, fainting, right? All right? You're going to faint if, let's see here, local anesthesia, right? You see the needle, you're awake, you're going to faint sometimes. Those will faint. If you're asleep, I don't really understand that number, but okay. No anesthesia, you know. All right, laryngospasm is an airway problem of the vocal cords. You get it under a lot of anesthesia. Water gets on the vocal cords, they close up. You give a positive pressure, it opens up. Bronchospasm is basically asthma. You get it again under. You don't get bronchospasm, laryngospasm when you're just getting Novocaine. You don't get it. Okay, unless you're already asthmatic and you know running 10 miles, you get exercise-induced asthma. Allergic reaction, you know, pretty self-explanatory. Hypotension, all anesthetic drugs that I use, Versed, fentanyl, propofol, can give you hypertension. Angina pectoris is chest pain. You don't get it in the general anesthesia population because they're asleep. They can't tell you I got pain. All right. So remember that patient that has pain. I'm not going to put them moderately asleep, lightly, because I want them to tell me. So see this number right here? It's actually less than that. Or it's actually greater probability right here. So the awake patient that has chest pain that takes nitro is probably going to have chest pain on you. Dysarrhythmia, that'll happen with most any type of general anesthesia. All right, drugs I use, these are IV. Versed is like Valium. Ropanol dries the mouth up. Fentanyl is a narcotic. And Decadron, and then I did not put propofol, I don't know why, but there's Gravitol. It's a derivative of that sodium thiopental or thiopental back 20, 30 years ago. Okay. Oh, this is referred to me in Columbia, a guy Nermo, goes to North Orangeburg, big cyst right here, hard impacted tooth. You know, I got to make a decision, do I want to do this in an office or here? And this is pretty easy to do in an office. So here's where the sort of the medical part in me and our profession comes into play, is I go through what's called a SOAP note, subjective, which is what the patient says, objective is my exam, assessment is my diagnosis, plan is what I'm going to do. This is a little bit more detailed of a SOAP note, and you'll find that in medicine and then oral surgery, is that you go through a chief complaint, quote what the patient says, next is a history of present illness, followed by a medical history, depression, seizures, heart, and just, I always start top to bottom, so I don't miss anything, try not to miss the thyroid or the diabetes. Then I go a clinical, an exam that I see, this exam, an x-ray exam, then I come up with my plan. I put all that together, and I say, okay, we can do it this way, or this way. And that's all based on experience. You gotta, again, find your way and what suits you and what you can and can't do. So, I tell the patient, I say I can do local anesthesia awake. I can do awake with laughing gas. I can do this IV sedation, different levels again, or general anesthesia, or that big old guy that can't open and got a big infection, we're going to the operating room, or where I need medical help. Okay, here's that, close to that guy. All right, so here, I'm going to determine, this guy's got a wonderful airway. Okay, first off, he's 16, probably a buck 20. All right, so good opening, great airway, I'll do this all day long and not have an issue. This guy can't open because he's swollen down here, he's got pus draining, it's from a tooth. I'm not going to do him in an office. A, I probably couldn't get a numb. B, I couldn't control an airway. And I couldn't put him asleep enough to not feel anything, or else he'll just thrash. So I'm going to do my whole medical history. I'm going to look at my airway. This is what I was talking about with the sleep apnea patients. How much can they extend the neck? The size of their neck. So then when we listed the heart and lungs, probably going to find some obstructive sleep apnea, coughing, he's probably a smoker. And then I'm going to give my orders. And then we're going to go to the hospital. I'm going to let anesthesia do their job. I'm going to walk in the operating room and just do my simple job. That's the easy part, whereas in the office I got to do it all. All right, this is just sort of what this is getting clearances. This is where I work with internal medicine, primary care, oncologists, and patients that come in that I've seen for the first time. I've never seen them before. You know, they've got maybe a crazy disease, or they got cancer, and they're on chemo, and I've got to have this tooth out, doc. It's killing me. I can't sleep for 3 days. Well, they're on chemo, and their neutrophils, which is their healing, and well, white blood cells, and then neutrophils is kind of right below it, is just out of whack. They're not going to heal. They're going to get infected anyways. So I say, okay, Dr. Oncologist, what can we do? How can you help me? How can I help you? Because he doesn't want me to do anything either while they're on chemo. All right, bleeding disorders. Von Willebrand is a form of hemophilia. Of course, you got hemophilia A and B. You got alcoholic cirrhosis transplants. All these are bleeding disorders that we can do. This we can transfuse pretty easily with vasopressin. It's just an antidiuretic. That's factor VIII. Hemophilia, you know, y'all know the deal with that. You're actually getting factor VIII. And then alcoholics, liver disease. Of course, that's end stage type of liver disease, and then the transplant patient. Everybody cool so far? Am I going okay? Mm-hmm. Timing okay? All right. We're getting there. What is our role? So, this tooth right here, tooth number 5, it has to come out. Well, dentist tells me it's got to come out. Patient got to tell me, all right, it's coming out. All right, so that's what I do. You know, I take that tooth out, I measure the root length, I look at this area. We're going to bone graft because I want to place that and 4 months later. Or I can place it immediately. In this case, I placed it immediately. Yes, sir?
What's the difference between the dentist taking out a tooth and you taking out a tooth?
None.
None. So why would he send him to you?
The preference. I'm trying to say it's different. Typically they charge more because it's taking more time. So their chair time is money. Okay. They're usually better at other things, such as fillings, crowns, and making more money. Okay? And treating other parts of the mouth rather than taking a tooth out. And I'll just tell you, taking one tooth out covers the expense. I am a person that treats the patient first, does a good job, money will come. On the other hand, and so what I'm saying is that for $215, I take that tooth out. It takes me 2 minutes to take it out. They take the dentist for 20 because they want to be careful. They don't want to break anything off, so they can send it to their own surgeon. All right, so there's a pride factor as well. But it's sometimes they see it as money too. So there's no difference.
How do you take it out?
Well, that's a good question. This is actually the most least invasive way. This is almost like a little pick, a prior. It's like a wedge. You just wedge it in between the bone and the tooth. The tooth is connected to the bone by little fibers. Okay, they call them, every one of everybody's tooth here is connected by little, what's called Sharpie's fibers. All they are is little ligaments that are microscopic. The tooth moves because of those fibers. Okay, so you just wedge in there, and there's two ways to take a tooth out. You either make the hole bigger, which is the bone, or you make the tooth smaller by cutting it up. That's just two ways to take a tooth out. So if you get stuck on an island, you take a tooth out, that's what you do. Or you become a dentist. Or a doctor going into Honduras or something. Happens all the time. Okay, so implants placed, and then the crown is placed that day. This is a special case. We don't do a lot of those immediately. We usually extract, put bone in there, let it heal for 4 months, place an implant, and then the dentist places the pretty part I think you were asking about. And I don't do well. Okay, this is another way to graft. So these are ways to graft now. That hole where that tooth was, this is a tooth that's been missing, and I want to go over this in the case in just a second. This is a tooth that's been missing for a long time. Bone likes to be around teeth, so if you can retain teeth, you'll maintain bone. This patient wanted an implant. This patient wanted an implant. I wish I could show you the defect on this one. It's crazy. It's a big hole due to an abscess. This is the block. That block is almost it's not the same person, but that block right there, it was that block 6 months ago. This is now the integration of a bone coming from the mandible, the site where a wisdom tooth is. I cut out a piece of bone, just plop it on there, drill, with these 2 screws. Put 2 little small screws, 8mm screws in there. Patient never feels it. 6 months later, you come in, you got that, you then drill your holes. I'll go with that just a second. Okay, this is just how bone kind of forms. Osteogenesis is like stem cell. Stem cell is the basics, and then you got osteogenesis. Kids younger than 13, if you cut off a kid's jaw because of a tumor under the age of 13, it's been shown, every kid does it, that they will regenerate bone and it will be up again. And the reason is this. Mesenchymal cells, which are stem cells, which are in embryology, if y'all had it, you've got these certain cell lines. You have neural crest cells that go and form limbs, and then you got these mesenchymal cells that go to form bone, cartilage, connective tissue, muscle, okay? So these are certain bones, and so what happens is, they say, okay, I got a bone defect, well, I'm going to go and transform into a bone cell. It's called an osteoblast, okay? And go and add bone. Then you got osteoclasts, which are packing in, come and eat away bone. So at age, for every 10,000 blood cells, or cells, sorry, in the body, one of those is a mesenchymal cell. They can be pluripotent, so completely potential. 1 in 100,000, and then by 80, 1 in 2 million. That's why we don't heal. From talking and I'm just talking basic level here. I'm not an oncologist by any means, or a hematologist, but that's the basic levels that I know of. This is PRP, platelet-rich plasma. Blood is drawn by an IV. I separate it. Actually, it goes into this machine. It is centrifuged. These are platelets. Platelets are the first thing that comes to a wound. Tiger Woods had it injected in his knee. Probably heard of that. You've probably heard of other people having injected his knee. Probably Robert Griffin III. Probably that other running back down south here. Had operated on by James Andrews. Or injecting this. Supposedly, it promotes healing. There's a big controversy in that. Okay, so if you inject platelets and it actually promotes healing by increasing the density of the area. It has all these enzymes in it that you'll learn. And this is what it looks like. It's like a putty. So this is actually bone, just a little bone out of a bottle. It comes from a cadaver. It's been sterilized, and then you squirt all this on here. It becomes a little glob. Okay. This is just the cascade of clotting, and all you need to know about this is you get a clot immediately, then you get an inflammation process, new blood cells. By day 14, you get new capillaries forming. This is how a tooth socket. You get a tooth taken out, this is how it heals. You get a blood clot. Then you get inflammation. That's why you swell, or you swell inflammation. You get new blood vessels. Then you get, by 3 to 14, this is what I tell every patient, by 2 weeks, you're going to have complete revascularization of that area. It may not be bone, but it's complete revascularization. And then that hole will probably close up and be complete bone, new bone, by 6 months. So if you break your leg at 6 weeks, which is 42 days, or break a jaw, I tell the patient there's going to be immature bone there and mature bone. The woven bone for histology people, woven bone and immature bone, or immature bone. This is just uses of PRP. Okay, so again there's just some big bone grafting. All right. So for those that are wondering about implants, yes, we do implants. You know, that's kind of a big thing. You guys do implants? Yes, we do. We do a lot of them because we take a lot of teeth out. So that's how, you got 4 options in dentistry when you take a tooth out. Okay? Just think about the front tooth. You can do nothing. Okay? From West Virginia, they do that. Sorry, I apologize. 2, you can do a partial, like a little flipper. 3, exactly. No, we don't want that. 3, you can do a bridge from one tooth to another tooth, like you're cutting on the other teeth. 4, you can do an implant. Well, you're dealing with one tooth, let's just deal with one implant. So that's how you do that. So you bone graft, you block graft, and then you can do what's called a ridge split. Ridge split is like taking a piece of wood, you want to chop wood, taking a piece of wood yay high, taking an axe, cutting halfway through it, spreading it apart a little bit, and driving a nail or a screw right in the middle of it. That's so the bone can be wide. You don't want to place a screw like that and have the thread showing out the side. Because with any carpentry, you're going to know that's going to splinter off and it's going to fail. So what we do is, with that, these could be in reverse order. That could be up here, but anyways, you do that, and then you do that to cover it up. Okay, this was, I think this was Willie. A lateral incisor was missing, and then he was going to get that crowned. So that's just this is how you take this tooth out. Just kind of go down the little fibers, nice and slowly. It'll pop out if you're using the correct pressure. That's what you got. You got a defect because of an infection. Okay, so what I decided to do is, hey, we got a defect. I got a bone graft. All right, so we put some bone here, and then we suture it back. Wait 4 months. Oh, so we go from here. 4 months later, we're here. You can tell. You can see all this. That bone is not as dense as that. Okay, but it's dense enough. Everybody see that?
How long was that?
4 months. The block grafts need 6 months because it's taking a block from just here and just smashing it here. So this needs 4 months so I tell every patient, if we're going to take a tooth out and we're going to put bone up in there, I need 4 months of healing. Well, doc, what do I do in the meantime? Talk to your dentist. No, I don't go. Like I said, here's your options. However, your general dentist is better at making this thing than I am. So you want to make a little flipper, take it in and out. You can make a little bleaching tray, put a tooth in that bleaching tray. Retainers that you go through orthodontics, that they do that. Those are ways to do that. Did that answer your question? Okay, so, oh yeah, that's my paralleling pin. That's that little thing sticking out again. And that pin sticking out. And that's all that's doing is, that's just showing me the direction of where I want to place my implant. Because if I place it way out here, guess what kind of tooth you're getting? So, what everybody says is almost, what we say is, a monkey can place an implant. A monkey can place a screw. But you got to put it in the right place so your general dentist doesn't get mad and he will still refer to you. So I'm making sure that that is coming out at the same direction as all these teeth, sort of in a nice semicircle. That's what I'm doing. And I'm matching it actually with the bottom teeth. While the patient's asleep, I can play with their jaw because they're so asleep. And then I can, all right, sorry, I'll stop there. All right. So this is what we look like. This is the canine redone. This is this. We got a little bit of a defect here. I don't like that as much, but if we shape this a little bit more concave, right here, you can get tissue growth in there. All right. One of my first cases in Columbia private practice, guy comes to me from a well-established dentist, and my partner is 55, done everything, from Iraq wars and all surgeon to who knows. But this guy comes to me and says, I don't like this upper partial that I'm wearing. It's covering about 5 teeth on the upper. So, and he's got this gap here, and this fake tooth here, and this clasp here. So I said, okay, smile for me. Well, you know, he don't really want to smile. I wouldn't. Okay, he's been wearing that for 40 years. Happy. You know, tailgates every Saturday. There's a home game. So I'm not a tailgate for that. Okay, tooth number 5. And these are just labelings of numbers. If anybody knows it, upper right is one that is 1 to 8. Upper left is 9 to 16. Okay, that's tooth number 5. Missing the tooth. That's where that flipper goes. Another tooth that's missing, where that flipper goes. Upper left. Again, right there you see the indentation. I mean, that's a pretty tooth, isn't it? Anybody want that? Okay. Got all this stuff in here. All right. So I asked him, you know, you start with your patients. What do you want in dentistry? What do you want? What's your goal? You don't say how much you want to spend, but what do you want? And then you can tailor it to that. A little bit different from medicine, you know, because dentistry is a lot of cosmetics to it. Okay. So there's his X-ray. Missing space, missing space, missing space. Partial. He's not concerned about the partial because the gravity's working well for him. So, okay. I asked the dentist, you know, a guy, he hasn't done a lot of implants. He's 65, sorry, 65, and he's young. And I said, what do you think? I said,
Appreciate that, I appreciate that.
Welcome. That's a new Fit 40. I said, well, what do you think? What do you want to do? I don't know, he just doesn't want partial. I said, well, what else would you do? And I'm going back now to my dental school days and said, well, hell, he needs a lot of work. I said, okay, well, what do you think? I said, well, I think he needs an implant here, an implant here, an implant here. And while you're at it, do you think you can go ahead and crown the whole front? I'm not going to do it. I'm going to place it. Well, yeah, that's a good idea. And so I was a former director in Columbia, because my partner, we owned it, the South Carolina Academy of Implant Studies. So every month we had a lecture with about 40 dentists come in that usually referred to us. We took them to Cancun and Bahamas too, and blah, blah, blah. But that's the problem. I haven't done it here yet. But I do want to go to
Costa Rica?
Costa Rica.
Ah, yes.
So I called him, I said, by the way, does he have a little diastema here? Oh yeah, he does. I said, and diastema is an open, okay, in between teeth. Usually in the African American population, but he had it because of a lot of tissue right there. And I said, well, what do you think about this tooth? Yeah, it looks a little bad. I said, okay, well, I got a problem. If I'm going to place a sterile implant right next to that, and then a sterile implant next to a tooth that's failing, it's kind of like putting Pirellis next to an old Continental. That's how I tell my patients. You know, like, oh yeah, I wouldn't do that. When I get a car mechanic in, they know it, they understand that. So, 3 implants, but now I got to review all this stuff that's going on anatomy-wise. Okay, this is what I asked the dentist to do. Do a diagnostic wax-up. This is perfect. This is what you're going to do first year of dental school that you go. You're going to artistically do these things. Okay, this is the defect I have. That's the block I placed. That's the back left where the sinus is. I got to go and do a sinus lift and put some bone there. Okay, implant. 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 6 months later. Reason being is the block graft and the sinus lift. I did it again on this side. I ran out of time on these, so I had to come back later and do that. Okay. There's where we are. That's redone. Or actually, one behind it you'll see is redone. But yeah, no diastema in the middle. Okay. You know, it's hard to get tissue filled in here again, but the dentist did a wonderful job. He really did. There you go. There's that new tooth. Don't do that. I don't like this bite. You see how this tooth is on the inside? Not supposed to be like that. But that's him. Okay. So he's happy. We did it before the first ball game of the year. We started in the middle of the first one, and then we ended by the next year, by like what, September 1. Okay. 22-year-old girl, orthodontics twice. Okay. Loose teeth. If you can take away these implants, because this is virtually placed, basically it shows her, but these are all loose. So, yeah, we want to take them out because she can't keep them for another 20, not even another 5 years. Okay, so get the picture here. We're doing another model. This is what your orthodontist does, but hopefully with all your teeth. This is just a temporary, okay? We send this off, a CT off to a lab, we're doing CT guided. This is actually more CT helpful because they fabricate this. This comes out of like Terminator, like out of the lava and formed off a CT. And then I said, oh, perfect, you know, I can just drill some holes and I can just call it a day. Well, the problem is, and I knew this, is that she has thin bone right here. So if I place an implant here, in the next 20 years, in about 10 to 20 years, that implant's going to start to show because she's going to get older, everything's going to go up and recede, everything just changes. So what we got to do is I make my first pilot holes. Again, there's your little pins. See that cut right there? Same, that's the same cut. You see this cut right here? That's cutting, that's like chopping wood. You chop the wood, you bow it out, place an implant in, cross your fingers. Suture it up, put this back on, 4 months later. Now, not half bad, okay? But, I mean, it's a little raggedy here. But over time, that will fill in with good dentistry, yeah.
So when you split the bone, like what you call like splitting the
Bridge
wood,
split.
is that, and then you put the pins in, is that so that the bone will grow kind of in between it and just in the kind
That's a good question. You know, I asked my partner who started doing all that. I said, well, what's going to happen to all that bone in between? Well, we actually pack bone in between there too.
okay, and then it kind of just fuses together.
Now, we hope it does that.
Yeah.
Yeah, we hope it lives and does that. Okay? But we do know that we can do it and it be stable because we're actually getting anchorage up higher too. You know, we're only doing that the first 8 to 10 millimeters and that implant's about 13 long. Okay, so, all right. Okay, cool. Getting a little more gorier. All right. I forgot, who was this guy? What was his name?
Dr. Cherry.
Yes, that's not me.
Nah. Sorry. I had a question. So what is she supposed to do for 4 months? Like just...
Did you see that little retainer she was wearing? It was like a bleaching tray, or the little, what we call, an orthodontist calls an Essex retainer, okay? For anybody that is missing a little tooth, let's say they're 15 and they can't have an implant yet because they're still growing, the orthodontist makes them this retainer. It's like a suck down. It's like a bleaching tray. And they put a little tooth in there. And you just take it out, pull it up, take it out.
Like right after surgery, or is she just supposed to like walk around with
She walks around with it.
Okay.
She walks around with it. But remember, she's going to pull a low lip. She's going to pull that low lip thing. You know, she's only talking like this. Or thereabouts. Okay? I mean, there's other options. You can do the flipper, the partial. I don't like the flipper because it bangs. People eat with it and it bangs. This actually sits on top of the teeth. And if you try to chew on that, it just flexes and bites. So we tell them we don't chew on that. You're on a soft diet. Macaroni and cheese, mashed potatoes. Did that answer your question?
Pardon?
Did that answer your
Oh,
question?
yes, sir.
All right. Got about, how we doing? 20 minutes? 15 minutes?
Mm-hmm.
Okay.
All right, big cysts. We got cysts and tumors, okay? Not necessarily carcinomas or cancers, but teeth make cysts and tumors. Some you have to resect or else they will come back and get very, very large. That's the nerve, that's nerve reconstruction. Okay. Okay? No bone. Tooth is way up here. Okay. So this is a prelude to some cases, and then we're gonna wrap it up here. 29-year-old male in Boston, cousin of my attendant. Okay. Can't believe you're hiding in DC. But he's missing this bottom tooth. He's got some recession down here. He's had some trauma. Okay, he had a jaw fracture actually, and then these upper 4 front teeth. Oh gosh, no more than that. Sorry, upper 6. Okay, canine to canine are missing. This is typical of any head-on collision. Wrong way. Okay, fixing the jaw fracture. There's a fracture right here. Okay, so this is the initial day 1, or first week or 2 after you come into the ER. All right, you still got an extraction socket. These teeth are hopeless. Let's get them out of there. Let's sort of start over. This is a dental CT. Okay, upper jaw, not the same guy, but this is just. I'll go back to the same guy. Bone, block bones placed. He wanted a jaw advancement, a chin advancement. They were in an academic center. It usually is free. Okay, so we do a chin advancement, put some block here. You see all these pins, screws. This is what he looks like now, a lot fuller. More blocks, still CT. Surgical guide made by the dentist and who we work with. Those are the ugly pins again, we just leave them like that. That's during surgical time. That's how we leave them, okay? That's how we leave them. And we give them that little partial or that little thing that we were talking about. Okay? This is what the lab does. No, this is, okay? This is what the lab does. He comes back, we try these in. I don't do this. This is not prosthodontist. You should get Dr. Horton here in South Carolina, or in Seneca. So we go from here to here. Out of focus, a lot of red in that. So hopefully the tissues don't look that red. Okay? All right, this is what oh, by the way, all that combined is good dentistry. So we go, you can imagine, from not smiling to smiling to a better facial profile because we did a chin.
Just threw it in the chin.
That's free. that Mass Health, free care. It's yeah, Washington. Anyways, this is one I published in our national journal with my attending. 16-year-old comes from, gosh, somewhere up in Massachusetts. Big expansion of his mandible. He's getting numb because it's pressing on the nerve. It's expansile. He can't chew, can't bite. He's got some nodes in his neck, and then you're like, uh-oh, this stinks. Okay, you got this big old thing eating away at the bone. Okay, if he takes his brother hits him, he'll fracture his jaw right here. This is just cancer cells. The pathologists look for different types of cells of what cancer could be. So we refer, and actually we do a joint surgery with the ENT there at the reconstructive ENTs, head and neck cancers there at Boston Medical Center and BU. They do, we do the resection. They go and harvest a fibula. It's about 8 millimeters high, maybe 12, depending on that. And so they do a fibula, and that's just to reconnect the jaw to the condyle, so you can have continuity, and the guy can still open and close. Okay, after this, he can still open and close. So he had a pretty rare tumor. That's why it was published. Come back a year later, we go and get bone from the hip again. There's that fibula still there. You love this, don't you? And then we pack a lot of bone here. You can actually see the fibula is still here. 6 months later, there's the bone. So what are we going to do next? Of course, we're going to replace some implants. Get a dental CT. Everything's easy now. Our general dentist do that. Oh, so that's it. Sorry I didn't show his face. We lost him to follow-up. We don't know if he died or not. Actually, mealovascular carcinoma is pretty, it's about 50% mortality.
So they got rid of the tumor, what, as much as they could?
It came back.
Okay.
I heard it came back. But yes, what you do is you get margins, then you go and do a radical neck.
They took out like half of his teeth on the side, right?
Oh yeah, took his jaw, whole jaw and everything. Yeah, right in the nerve, and then make sure you get margins, 1.5 centimeters, just so you're not getting, leaving anything behind typically. But he had this neck, it's in his lymph nodes, so he got radiation for that, and actually had him taken out too. So it came back, and probably did not survive. Simple jaw fracture, 7-year-old MVC due to a drunk mom in Richland, in Columbia. A lot of sad stories. This is just a pretty easy mandible fracture. This is what they look like when you dissect down the chin. You do this, you place a bar. Of course, they're wired shut first because you want to put the teeth together. If you can put the teeth together, you can repair any bone in the body. That's sort of our landmark. Okay, put the teeth together via wires. They're wired shut, and you can put almost any bone together. Simple. Of course, we treated with that one, just kind of wiring them shut, and that will fuse back if you don't move. Okay, quick case. This is one of my most interesting ones. 16-year-old, not the MS-23 gang, but the Forever Over Latin Kings gang in Orangeburg, South Carolina. Arrested juvie before, 14 or 15, mom's on crack. Another agency SLED team raided the house. Mom went and opened the door. She has I think a 1-year-old in the house too. He's 16. They throw those bang grenades in, the smoke. Well, he caught it. So I found out from a SLED agent right across the street. I said, how long does it take for those things to go off? What the heck's in them? And why the heck did it do this? Well, we don't know. That police report, and I found out that because we can see everything in the hospital. We entered, we did this, we left. Okay, well obviously there's an investigation going, but SLED didn't exactly, or that city did not exactly repeat too much of what happened here. So this is me seeing this. So I'm flying about 100 miles per hour, there's a big tractor trailer, 926, the chemical spill, and I'm going around the whole thing. Trauma surgeon's calling, hey, can we take him to angio? And I said, no, just let me get there because usually we can tie these things off. So what we got here is half the lip is gone. This is all just macerated from like an explosion. This is almost like a gunshot or a shotgun. And what I've done is taken the tongue and just tied it to the drapes just to get everything out of the way and clean it up. Okay? All right, this is where we are 1 week. Okay, so we go from here to here, 2 months. Okay, all that's doing is treating the bone first in the mandible fracture with a big plate, put the bone together, put the teeth together, then you can just piecemeal all that, and that was about 5 hours with a secondary surgery to reconstruct the lip. Boat propeller guy. So when I first got the call in Boston Medical Center, I was just going crazy, I was busy. I heard plane propeller. Well, the guy fell off a boat, quick turn, by the thing, he went off the side and then also hit his axilla. So this is what we get. It has a mandible fracture, has a lot of soft tissue. That's perfect access to go and replace that. So you go and fix that first, and then go and suture and make it pretty later. That's us going in, wide open, big plate, repaired. Okay, last little thing, and I'll run through this. This is your Fosamax, your Actonil, your Boniva, your Reclass, your Zometa that treats now breast cancer metastasizing to the bones, prostate, potassium, and multiple myeloma. For those last 3 IV forms, they're using IV drugs and very aggressively in Greenville, less aggressively in Columbia, the South Carolina Oncology System, to treat these cancers. They save lives, but they cause us headaches. There's an oral form, like I said, so let's see here. Just the demographics, it's going to save the medical industry billions of dollars for hip fractures and deaths and all that. These drugs, Fosamax, Actonil, Boniva, those are the ones you take by mouth. There's a 0.01% chance of, if you take a tooth out, if you've been on one of these drugs for 3 years, and you probably all have people that you know that are on these drugs, that they will have exposed bone after a tooth extraction. That's because the mandible turns over at a very fast rate, and it just doesn't repair because these drugs are trying to kill off the bone via bone-eating cells. IV, much higher. We're now seeing about 8 to 30% chance, and now everybody knows it. This is the newest drug on the market. It's given once a year. It's not to treat. It's just treat osteoporosis only. It's well tolerable because it's only given once a year. These are things that are eating away. That's the cancer eating away the bone, so they're trying to stop these things from eating the cancer eating away the bone. Well, it's not allowing the bone to turn over, which you need for healing. More frequent in the mandible and maxilla, alveolar bone, 10 times, which is the mandible bone, is 10 times greater turnover than tibial bone. So your tibial bone, if you look at it in 6 months under a microscope, is not the same cells. It's the same bone, but it's not the same cells because there's 6 months of turnover. But the mandibular bone does it 10 times faster than the tibia. Let's go forward so we can keep going. So we were seeing the bone get exposed spontaneously after extractions, after cleanings, deep cleanings, after implants. So basically, if you have an elderly patient, which is usually the 45 to 50-year-old female that starts to kind of go through the little x-rays of the hips and the bone density scans, and your doctor says, oh, you want to go on the Fosamax or Boniva or Reclass, have them go to the dentist. Just a little word of advice. We all have protocols. Most dentists send them to us because they don't want to take the tooth out because they don't know the protocol. Okay? But there are generally safe procedures for that, just crowns or just a root canal filling. Last case, this is a patient, and I'll show you why this is stage 0. Stage 0 means this bone, don't look at the stage 1. Stage 0 means it is exposed, but actually, I don't want to have stage 0 there. I think I messed up. Stage 1 is exposed bone, no pain, so just keep it clean. Stage 2, exposed bone with pain and evidence of infection. Chlorhexidine is just the soap that you use and the things, but it's in a bottle form. Then you give antibiotics, and then you do cultures, and maybe IV antibiotics or hospitalization for pain control. This is what they used to. This is what they were doing in 2003 up to about 2007, especially down in Miami. The oral surgeon guru that sort of was on the Novartis and Merck board to investigate this. Nothing was working. Debriding the bone, peeling it back, and nothing was working. That I think people just said, just cut my jawbone off. And this is actually a true story, because I went to his lecture for my boards in 2007. His oral pathway lasted an hour, or I mean a week. It's the most boring thing I've ever been through. And he was showing how they were doing hemimandibulectomies, which is half the jaw is gone. But now we're actually treating it aggressively a little bit more, just kind of come back, and we'll take away more bone. Okay, this is it, I think. Boston Medical Center. That's just going to change this too much. And that's it. I've done this lecture for about 300 people. I've done it for 10